is there any progress towards being able to give donations of blood to make IVIG in California? Actually, the collection centers for IVIG are all located in the center part of the United States. They're highly secret. No blood that's donated into the normal system is ever put into IVIG. The manufacturing of the IVIG is actually kind of a secret. And the blood centers were chosen by these large companies like Baxter for the product that we use here in San Diego. They chose collection centers in the middle of the United States because they thought they were less risky for bi-coastal behaviors, which they thought involved more risky sex and drug addiction. So we were interested when we met for the first time with the head of Baxter Pharmaceuticals to discuss some issues about IVIG, and we found out that one of their collection centers was in Fargo, North Dakota, which is actually the methamphetamine capital of the United States. So I guess that plan didn't backfire, it didn't work out too well for them. But it is a complete secret, actually, who are the donors for these blood samples. It's not taken from normal blood donation. It's taken from people who actually go in and are paid donors to give a very huge volume of the clear part of the blood, and then their blood cells are given back to them. So it's plasmapheresis, and we don't know where it's being done.
Two good questions. Two people asked the same question, which means it's an even better question. If the echocardiograms were clear, should any more be done? Or if the initial echocardiogram shows no damage, is it necessary to follow up annually? Or is it a given that once you have KP, you need to continue follow-up forever? So I would say, and Dr. Burns can add to this, if the initial echo and the discharge echocardiograms that follow up were normal from a trusted site that's used to treating KD patients, you should finish the short-term follow-up, but I don't think, no, you don't need to follow up forever, annually, anything like that, based on the data that we have right now. I think that those folks probably are, those kids probably are in really good shape. Would you agree with that?
Yeah, I think for now, because many of our patients who are at the age where they're being discharged from care, so these are our children who are now turning 18, if they had their Kawasaki disease 18 years ago, which many of them did, our echocardiography in terms of just the sensitivity wasn't perfect. And so we actually are now doing, based on the data from Lori's study, we're recommending CT calcium scores on all of those people before we turn you loose. No exercise testing, but a CT calcium score.
And that was the second part of one of the questions. Do we need a CT scan of the heart just to be sure? Especially now, as the CT scans have come way down in radiation and are really no risk, I would say. Okay, and I'll finish my thought, and she's asking me to explain some of the medical differences between the tests that we recommend. As the radiation dose has come down so much over the past even few years, I have no hesitation in saying it's virtually risk-free test. And so that whole just to be sure, I think is a good idea, as Dr. Burns said, especially if the echocardiograms were a while ago and maybe not as fine-tuned as we have now. Now, Dr. Burns asked me to explain the difference between a calcium score, a CT calcium score, and a CT angiogram. A CT calcium score is basically a snapshot CT scan of the heart that just looks at the calcium. It does not give you information as to the shape or health of the blood vessels. It doesn't inject any contrast. You can't see the insides of the blood vessels. You can only see if there's calcium there. It's a shorter test and very slightly less radiation. A CT angiogram can sometimes be done at the same time as a CT calcium score, but is the additional step of injecting some intravenous contrast through an IV in the vein and you get a picture of the coronary arteries and can actually see if there are aneurysms or blockages. It takes a tiny bit more radiation, and it takes an IV and contrast, but can be done at the same time. Interestingly, and this is just an aside, because I order these a lot for patients for other reasons, insurance generally will cover a CT angiogram with a calcium score if it's clinically indicated. I have yet to get an insurance company to cover just the cheaper version, which is just the calcium score.
Get cases tracked and do a better job of understanding the actual burden of disease that we have in this country. John might want to have some comments about that. He lives in the Beltway, and we've certainly flown to Washington and tried to raise awareness among our members of Congress. The NIH, which is the National Institutes of Health that funds most of the biomedical research in this country, is and should be absolutely immune to outside influence. And I think that's right. It needs to be a group of our peers who judge the quality of the grants, and I don't think that there should be a lot of pressure on the NIH to decide which projects get pursued. But having said that, there are certainly lobbies that went to Congress, and at least with the budget for the Centers for Disease Control had a big impact, and one of those lobbies is the group that are involved with chronic fatigue syndrome, which we don't really know what that is. And the chronic fatigue syndrome folks, through congressional pressure, were able to get a line item on the budget for chronic fatigue syndrome at the Centers for Disease Control. In fact, the head of the CDC was fired because she couldn't figure out how to give away all the money, so she used some of the money for something else, and they found out, and she got fired. So, I think public pressure doesn't hurt. I guess I'm not super optimistic about how you move boulders. Don, do you want to comment on that?
Well, yeah. We could even get a chronic disease resolution passed to the Senate. Again, so if you're going to do it, it's obvious.
Yeah, so I don't want to discourage you. If it makes you feel better to write a letter to your congressman about how Kawasaki disease research is underfunded and underrepresented, by all means do it. It's certainly not going to hurt. But I guess I'm a little bit jaundiced after our initial attempts and my, Pollyanna concepts of how I could change the world.
This question asks, well, we just said that if your calcium scan is normal after 10 years, your echo is normal all along, maybe you don't need follow-up. This question is asking, what if the child needed an additional dose, more than one dose of IVIG in the acute phase? In other words, implying maybe a more severe or more active disease. That's an excellent question, I think, Dr. Burns, that probably we don't have the answer yet to. I think overall we're not seeing that those individuals are at particularly higher risk, but it does lead us to kind of an open door, I think, and it's part of the reason we're still following people in our study, hopefully 10 years, 20 years out, because is there a chance that way down the line, other things could turn up? Sure, there's a chance, and that's why it's important to stay involved and keep your ears out for things. I think the chance of that is low, but probably not zero. We just don't know the answer.
So I think Dr. Franco's immunologic studies are really going to help us understand who's at risk for coronary artery damage. And my hope would be, and Alessandra, I don't know if you want to comment differently about it, but
with this discovery that we recently made of this regulatory T cells that recognize portion of the immunoglobulin, we are capable to predict children that do not respond with these regulatory T cells to BFC after the first infusion. They're unlikely to respond to a second infusion. And we know that these regulatory T cells are the critical ones to really heal the inflammatory status in the artery. So we do have today an early predictor of the possible outcome of second IVIG boost. And hopefully very soon we will also discover what are the defects that lead to the lack of this regulatory T-cell response.
There's a question here asking for some follow-up of the mouthwash and the DNA collection that many of you have been participating in. So Dr. Tremoulet and I and Shisato Shimizu, who's sitting here in the front, who's the director of our genetics program, have been collecting your spit for many years now. It takes thousands and thousands of samples to actually perform the kind of genetic studies that we're doing. And we just hosted last week the International Kawasaki Disease Genetics Consortium here in San Diego. We had about 25 investigators from Australia, the Netherlands, Singapore, Western Europe, the UK, all here in San Diego, and it was a fantastically productive meeting. We work collaboratively with this huge international group because we want to, but also because we have to, in order to get enough samples. And our most recent initiative is to bring Emory University and the Combined Children's Hospitals of Atlanta, where they actually each year take care of the largest number of Kawasaki disease patients in America. And we're the second largest site, but Atlanta wins. And part of that is because of the large African American population there, and I shared with you earlier the increased susceptibility. African Americans have been excluded from every genetic study that's ever been done because they never had enough numbers, and you have to have enough numbers to actually perform this kind of work. So the NIH has invested in us a small amount of money to allow us to begin collecting DNA samples in Atlanta, but it will be at least a couple of years of collection and then actually running the genotyping before we have any answers about that. But everybody's mouthwash has been used, everybody's mouthwash has been turned into DNA. Most of it has gone to Singapore, where we're doing our genotyping at the Genetics Institute, there, the Genome Institute of Singapore. We appreciate your help. We also understand the frustration that it takes so long to do these studies. As I mentioned, the whole genome sequence analysis has been ongoing for 18 months with 2 huge teams of people, and we're just now starting to get a glimmer of some exciting results. And your DNA will be used to confirm those results. So it is ongoing. We've had a real hiccup with the funding situation. So we lost our funding of our genetics grant in 2010, and our attempts to get it refunded by repeated applications so far have not met with success. So since the sequester, it's been a pretty grim time. But the good news about DNA is that it lasts in our freezer forever. So we're not going to give up trying to get refunded so we can make faster progress with this. But it has hit a bit of a slowdown due to funding issues. We can't do this without funding.
This question asks whether it's recommended for KD parents to have a calcium scan or other tests for heart disease. So it's a really good question. It's recommended based on your own personal risk profile, not any different because of the fact that you have a child with Kawasaki disease. So if you have a lot of heart risk factors in your family, if you have high cholesterol, if you have high blood pressure, things like that, I would recommend talking with your doctor and or a cardiologist, and that would be a decision really separate from the fact that you have a child with Kawasaki disease. The second part of this question, though, talks about a child who had KD at 2.5 years, and most of the men on the mom's dad's side of the family, so the maternal grandfather side of the family, have died of heart attacks. Is that any higher risk in my child who has Kawasaki disease? Which is another interesting question. And I think an important point to leave here with is that the heart artery problems that develop after Kawasaki disease are very different from the heart artery problems that we get from normal aging, from eating donuts like the ones I showed you, from not exercising and things like that. If you look at the arteries under a microscope, it looks completely different after Kawasaki disease versus your typical run-of-the-mill heart attack. That's not, as one of my mentors used to say, just because you have lice doesn't mean you can't have fleas also, right? So if you're unlucky enough to have had Kawasaki disease and a family history of horrible heart problems, I think it's wise to kind of attack it from both ends. But it's kind of two separate problems. And Dr. Burns can speak to the fact that some studies have shown that kids with Kawasaki disease heart aneurysm problems may have some degree of protection against the more typical kind of heart attacks. It's kind of a surprise, maybe a good finding. Maybe it's because the arteries get thickened and fibrotic that the cholesterol can't enter them as well, but they tend not to have typical heart attacks. I'm not so confident in that information that I would say, okay, go out and, you know, eat hamburgers for the rest of your life, but that is some interesting data.
So Dr. Tremoulet and I face, not infrequently in clinic, parents who come in saying, well, my child's had Kawasaki disease. My mom says that I had prolonged febrile illness when I was a kid, and so we try to ask some key features, and here's what I would ask your parents, if you're one of those parents, and this is for moms or dads. Ask your parents, so your child's grandparent, did my eyes turn red? Because that's one of the differentiators between scarlet fever, which in a previous generation was a much more common disease. So a lot of those rash fever illnesses that you might be worried about might have really been scarlet fever. So the eyes don't turn red in scarlet fever, so that would be one differentiating thing. And then the peeling, I think, is kind of a key. And the parents tend to remember the peeling because it's so weird and bizarre that it's something that they might remember. But if you've gone through all of that and you're still worried about it, we have sent a number of our parents over to the San Diego Cardiac Center, which is our clinical site for most of our patients, and a stress echocardiogram, which you get on a treadmill and you have a sound wave test of your heart and its function, combined with the CT calcium score, we think is a reasonable kind of screen for people who have a maybe history that they're worried about of antecedent Kawasaki.
And we can do that at UCSD as well, of course.
Right. I mean, it can be done also through, if you have your own internist, that could be ordered through them. But this is probably a reasonable way to do the screening. There was a question here about the link between aspirin use and hearing loss, and I just wanted to clear that up. Aspirin is used in Kawasaki disease patients. It can cause temporary ringing in the ears in people when they're on aspirin, but not the very, very low dose that we give to our patients chronically. So there's no risk of Reye's syndrome, there's no risk of hearing loss or any effect on hearing with the very low dose that children are taking. However, hearing loss itself, sensory neural hearing loss, is very sadly associated with a small number of our Kawasaki disease patients. So any of you who have toddlers who are suffering from speech delay or having speech problems and have had Kawasaki disease, they definitely need to get their hearing checked. Our group, when I was in Boston, we wrote a great deal about sensory neural hearing loss in Kawasaki disease when we first discovered it. When it happens, it's less than 1% of the population of KD children, so we don't usually bring it up or discuss it in length, but it's devastating, it's complete, and it's permanent when it happens. It's actual damage to the nerve that does hearing, and it's a terrible tragedy when it happens.
This says, how did kids that have dilated arteries that were transient, but also not aneurysms, do in the studies that I was talking about? Because I mentioned that kids with transient dilation did better. What if it was dilated, not aneurysm, but not transient? We classified that group actually in the dilated, because most kids with dilated arteries are transiently dilated. A few are persistently dilated. So we don't have a ton of those, but they seem to fall along more with the transiently dilated than with the aneurysm group. So probably healthier, but we don't have enough of those to say for sure.
There's a question here about what's the difference between boys and girls in KD and why, I assume it's why do boys get it more often. And again, one of the targets of our genetic testing studies is to try to answer that question, but nobody knows for sure. There is one gene that's on the X chromosome that has been identified as a certain form of it as a risk factor in Japanese children. We haven't found that yet in Caucasian children, but we're still looking. So the X chromosome probably is going to hold the answer. All right, I think we're done. If there isn't anything anyone else wants to ask right now, we're going to be around and happy to field your questions. Thank you so much for coming. Thank you so much for your support.